what is a normal pulp, a healthy pulp, what is symptom-free, histologically healthy, mild transient. It is because it has healthy pulp fibers, so it will show mild transient response to the stimulus, which could be thermal cold testing. And as soon as the stimulus is removed, it should return back to normal. Maybe it may take a second or a part of a second more for coming back to health, coming back to normal sensation. So lasting no more than 1 or 2 seconds after the stimulus is removed is the healthy pulp. It is best to test the adjacent teeth and contralateral teeth first, so that patient is familiar with what is normal, and patient should not be foretold. Okay, because when you are foretelling much of the information, you are failing the EPT or any test. It's good to inform the patient that raise your, whenever you feel pain, just give a hint, raise your hand or something. But usually the basic crux of testing is, in the clinical situations, you will know more by the patient's response. If it is sudden, patient's expressions, facial expressions, eye expressions will tell you the story of the pain. It is a failure if patient has to apply mind to notice pain. Pain is inherent. It is instant. It should demonstrate by your test, and rather than the cortex being active and thinking about, okay, this is pain happening or not happening. Some patients may have a good threshold, good response. They may not experience pain because they are knowing it. And some may have a very limited threshold. Even if they are not having pain, because you are testing it, it would come to their light. So the major thing should be done is you should be very focused in performing pulp tests in terms of reading the patient's sensations. Okay, so this is one table of pulpal diseases sequelae. Okay, you all can work on my screen. Interesting. Okay, this is the normal pulp. And whenever there is a stimuli causing inflammation, there is first step to this is irreversible pulpitis, usually. Irreversible pulpitis, at this stage, if the patient reports to a dentist, it is easy to identify and revert back to the health. Okay, if the things can be managed and dressing can be given to the pulp at this point in time, it can go back to health, and no other area it can go back to health. Only with reversible pulpitis it is possible. Okay, then if still inflammation persists, we will have irreversible pulpitis, which is carrying forward of the inflammation and the battlefield. The soldiers of the immunity inside the body are a bit, losing ground. There are still the inflammatory mediators are now more active. Okay, they are somewhere close to winning the game. Now, depending upon what kind of inflammatory mediators and cellular responses happens, there can be 3-4 types of irreversible pulpitis. Basically, this term only signals now the patient cannot, or the pulp cannot go back to the normal health. It would either go to chronic hyperplastic pulpitis, that is also known as pulp polyp. We will go into details of this. Means the cells are producing, have gone into hyperactivity in producing more pulp tissue. Symptomatic irreversible pulpitis, it is the painful variant, where the inflammatory mediators are producing Rupert, Hubert, and the symptoms are happening to a patient. there could be a battle going on inside, which is asymptomatic irreversible pulpitis, which is not giving pain. The fibers of pain, sensation, C fibers, A delta fibers, they would have given pain in between, but the patient maybe had the high threshold, was already on painkillers, was having stronger defense mechanisms in terms of superseding the pain for the while, or it went on in a up and down manner. It never goes maybe in the same one attack of the pain. The inflammation would have rested in between, would have again got activated. So if that happens, sometimes a patient would not know of the, or may have 1 or 2 episodes of the mild toothache. They would have taken the painkiller and it becomes a asymptomatic irreversible pulpitis. Inside, the pulp would be dead, and you would directly see the radiolucency type of the radiograph with less of the pain. Okay. So this is asymptomatic irreversible pulpitis. Something can scintillate this, and any stimulus can again create inflammatory mediators to still whatever the fibers are active or live can still produce the pain. And finally, there would be death of the pulp. Pulpal necrosis happens. And then there is internal resorption variety. Here, odontoclasts get active. They start eating the dentine inside. There is a pulp canal tissue and the dentine surrounding this. So that is, we say, as internal resorption, because inflammation is happening within this pulp tissue. The dentin are being eaten up. So which is the boundary of the pulp, and that is inside. Something is eating up the dental tissues. It is internal resorption. Then pulp necrosis can also happen by traumatic injuries, which would be dealt in detail in the later part, and stimuli causing degenerative pulpal changes, which is calcific degeneration or calcific metamorphosis. Now, this can be replacement resorption, where externally the periodontal ligament cells are being replaced by the calcific material, which we say the bone material, and we also say that in external replacement resorption or ankylosis has happened. Or calcific degeneration can be inside the pulp tissue also, where pulp stones are formed. Okay. So are you all familiar with the terms?
This one.
It is all depending on what kind of inflammatory cells and what kind of cells are being active. If it is eating up cells, they can cause internal resorption. They can cause, if it is mostly internal resorption. External resorption is less internal pulpal tissue damage, but it can happen in trauma cases. Then replacement resorption more happens in when we reimplant the tooth. And calcific degeneration, pulp stones can happen with the chronic inflammation, chronic hyperplastic pulpitis, chronic inflammation. All these are basically chronicity of the inflammatory responses. Moving to the next slide. Okay. Our first step or the milestone which the pain takes is reversible pulpitis. Reversible pulpitis is associated with subjective and objective findings indicating presence of mild inflammation in the pulp tissue. If the cause, okay, 1 minute. There is a space between if the cause is eliminated, inflammation will reverse and pulp will return to its normal state. It is usually, it should be not asymptomatic, it is symptomatic, very much symptomatic. And application of the stimuli such as cold or hot or liquids may produce sharp transient pain. removal of the stimuli which do not normally produce pain or discomfort results in immediate relief. So the pain mechanism, usually the patient is sitting, when they say usually, asymptomatic means at rest. When the patient is sitting, it is not giving sudden pain. Only when the patient drinks a glass of water, juice, or have a sweet bite, then it suddenly gives pain. What is the commonest differential diagnosis of reversible pulpitis versus any other disease? Patient comes to you and says, he was having a sandwich, suddenly pain came. What would you think? A couple of diagnoses you would think would be?
Dentin hypersensitivity.
Excellent. So one of the initial thing is dentinal hypersensitivity. So how do you differentiate between it is dentinal hypersensitivity versus reversible pulpitis?
Yes, the cold and hot.
It is because of cold and hot
This
reverse
is an inflammatory.
stimulus.
Dr. Savera, okay, you can speak, please. Yeah, Dr. Savera, you are sharing.
It is because of hot and cold stimulus, ma'am. Reversible pulpitis.
Okay, and hypersensitivity won't be reacting to hot and cold stimulus?
Hypersensitivity. Dentin sensitivity is because of exposed dentinal fibers, whereas pulpitis is because of inflamed pulp.
Okay, excellent. So dentinal hypersensitivity, the major distinguishing factor here is dentinal hypersensitivity would be there would be exposed dentinal fibers, which would be class 5s or which would be mainly intact pulp. Say a patient is having dense vaginatus and it is having some percolation of the liquids, okay, or a faulty toothbrush leading to abrasions. Usually these kind of etiologies can be correlated to dentinal hypersensitivity. Whereas in reversible pulpitis, usually it is dental decay or a dental trauma, fracture leading to it. It is through and through insult to the pulp. There is dentine damage in reversible pulpitis. That's why it has reached the pulp. It is caused by inflammation. Whereas in dentinal hypersensitivity, the dentine may not be damaged. Maybe a bit of enamel is thin, or it may be enamel hypoplastic teeth, where the enamel is inherently thin. Okay, so but it needs a dental caries, or you need to have to see the clinical image of some disease per se to rank it into reversible pulpitis stage. And the patient will say the pain comes when I eat or drink anything, and it settles back after removal of the stimulus. After I stopped eating the sandwich, I cleaned the tooth with my, that cavity, there was a hole. I cleaned it with a toothpick and it settled down. That is the classic signal of reversible pulpitis. Cold and hot stimuli produce different pain responses in normal pulp. Okay, when heat is applied to the teeth with uninflamed pulp, that is the healthy pulp, initial response is delayed. The heat is mostly attacking the core fibers, which is the C fibers. First, it is attacking, the intensity of the pain increases as the temperature increases. Okay. In contrast, pain in response to cold in normal pulp is immediate. First, normal pulp is hyper responsive to cold test. The intensity tends to decrease if the cold stimulus is maintained. So it is the begin reaction, which is very, very particularly that change, that shift from normal to sudden application of the cold is the one which is showing the response. But if the cold is being present for long, there would be, homeostasis. The patient adapts to it somewhere. Then we have the typical etiologies include dentinal hypersensitivity, caries or deep restorations. Dentinal hypersensitivity can lead to reversible pulpitis. If you don't do filling for an exposed dentine or a layer from where there was continuous leakage of the fluids into the deeper part of the tooth, it would continuously keep on insulting and it will lead to inflammation of the pulp, which is reversible pulpitis. Caries and deep restorations, definitely. If the pulp is not protected, it would lead to this reversible pulpitis. There are no significant radiographic changes in the periapical region. It is just at the level of the pulp. And the pain experienced is not very spontaneous. Not spontaneous in the sense patient sitting there having a conversations would not have pain. Spontaneous means by itself, there is no stimulus involved. So that is the nature, it is not spontaneous in reversible pulpitis. Following the management of the etiology, example caries removal plus restoration, covering the exposed dentine, the tooth requires further evaluation to determine whether the reversible pulpitis has returned to normal status. Although dentinal sensitivity per se is not an inflammatory process, all of the symptoms of this entity mimic those of reversible pulpitis. So as discussed before, that this is not inflammatory, but the pain variant, the most crucial, critical differential diagnosis is between reversible pulpitis and dentinal hypersensitivity. For irreversible pulpitis, you would be sorted. Either the patient would have sharp shooting night pain, those kind of things, or will not have a pain. It would be going towards the death. Removal of the irritants and sealing and insulating the exposed dentine or vital pulp usually results in diminished symptoms. Is reversible pulpitis clear to everyone?
Excuse me, ma'am.
Yes.
Ma'am, how will we differentiate between dental hypersensitivity and reversible pulpitis if patient comes with pain to cold stimulus, or sensitivity to cold stimulus? Then how we will differentiate between those two?
Okay, when the patient would say that I have pain on having cold drinks, it would also, just by knowing the history, you would not be able to much, you will have an idea where it is leading to, but the strong association you would make by clinical examination also. Suppose if the patient is having sensitivity in lower left, say tooth region, back lower left tooth region, and you would check for all the lower back teeth, say from 332, 3738, whatever is present. If the pain and your clinical examination, you see many class 5s, just the caries or the cavitated lesions, then you would deem it as more or less and not very deep. Okay, that would be hypersensitivity. And your three-way syringe, you would put water and air. The patient would shriek with the blast of air also. So that would be signal towards hypersensitivity. Whereas reversible pulpitis usually happens when there is a decay. Reversible pulpitis, it should have been, more or less the soft dentine, depending on the stage of dental caries. plus you will take X-rays. In X-ray, in IOPA, you would see, or even if you take bite wing, you would say caries lesion, the radiolucency approaching pulp. So that two things will give you more idea of reversible pulpitis versus dentinal hypersensitivity.
Excuse me, ma'am. What if the decay has not entered the pulp but is in the superficial layer of the dentins, even though it is considered as reversible pulpitis?
It is dental caries approximating the pulp. It will not have necessarily entered the pulp.
Okay, ma'am. So it is considered as dental caries and not reversible pulpitis.
Usually for reversible pulpitis, dental caries diagnosis is a must.
Okay, ma'am.
In dentinal hypersensitivity, okay, if dental caries is present, you would lean towards reversible pulpitis almost all times.
Okay, ma'am.
Okay, reversible pulpitis would not happen in a healthy tooth.
Yes.
It has to have insulted enamel and dentin and reach the core. But dentinal hypersensitivity can happen in a healthy tooth with just a weak enamel also.
Okay, ma'am. Thank you, ma'am.
Okay. Then we have irreversible irreversible
Symptomatic
pulpitis.
or asymptomatic, ma'am? Reversible pulpitis.
Reversible pulpitis, once again, please repeat the question.
Symptomatic or asymptomatic, ma'am?
Depending upon what you are reading the statement as. Symptomatic, it is disease-wise, it is a symptomatic condition. If it is asymptomatic, how would you say it is pulpitis? Some pain has to signal it. But in the normal sitting, the patient is not having pain. Is generally when the patient is carrying out the daily activities, walking, talking, sitting, watching the TV, it is asymptomatic. When stimulus happens, it becomes symptomatic. So depending upon how you frame or the question frames the statement as, the patient as a person would be symptomatic. It is a disease which is represented by, or we would say it is clinically diagnosed by its symptom quality. Okay, but some textbooks would give you the statement as usually asymptomatic, which I would say is a paradoxical statement. Okay. Can you understand the meaning?
Yes, ma'am.
Yes, ma'am.
Usually the patient is not having pain. The patient is asymptomatic. But as a disease per se, it has to express, he will become symptomatic the moment he has a glass of orange juice. Okay. Then we have usually also one more thing, that's the clinical determinant. Reversible pulpitis happens more with the stimulus which sticks to the teeth for long. It usually doesn't happen much with drinking cold water or drinks. The level, it can happen, but intensity would be less. It is when a patient bites onto something, a chocolate or a sandwich which gets stuck in a cavity. It takes a bit of a while for that inflammatory mediators to affect or create reversible pulpitis symptoms. But in hypersensitivity, it is very sharp shooting. The dentinal hypersensitivity is basically governed by a different theory. It's hydrodynamic fluid theory, where just the fluid movement creates it. For reversible pulpitis, even though we are talking in the microseconds values, but still it needs a solid food putrefaction to give a pain of reversible pulpitis. And the electrolytic, what do you say, the cycle or the battery cycle kind of cathode anode to create a thing which we test in the EPT and all. It takes a bit of a while in your reversible pulpitis. But in dentinal hypersensitivity, the theory is hydrodynamic. The fluid moves and it gives sharp shooting pain. Just the spot of a drink, just a kind of a one drop of the liquid can produce a pain, which is hypersensitivity. Just a minor thing if you can catch from the patient's history. Okay. Now, when it comes to irreversible pulpitis, we are far more sorted with this one. It is a clinical condition associated with subjective and objective findings indicating presence of severe inflammation in the pulp tissue. Now, the inflammation, our party, which is the defense party, is kind of losing. It is symptomatic, spontaneous, and lingering pain. The patient will have pain sitting. Just the patient would visit a dentist holding the cheek, holding the jaw, that it is very painful. Or maybe it is completely asymptomatic. Now it is so much devastated that even the nerve fibers are killed, no more there, it has become asymptomatic. But yet to become necrotic. Yet to become necrotic, why? It is yet to form the pus. Okay, the death is yet to result in putrefaction. It doesn't resolve even after the cause is removed. So obviously it is such a final terminal of the battle where it doesn't revolve even if the cause is removed. Pain results from an irreversibly inflamed pulp may be sharp, dull, localized, or diffuse, and can last anywhere from minutes to a few hours. Localization of pulpal pain is more difficult than localization of the periradicular pain. So pulpal pain, it's a very important concept here, is difficult to localize. Periradicular or periapical pain is easy to localize. So apical periodontitis patient will directly tell you this tooth is aching. In irreversible pulpitis, patient would be not able to localize much. Apical periodontitis has gone to the root apex. Okay, so the patient is able to localize it. Tooth would feel lifted. It would, when you do tenderness on percussion test, it would react. So that is more possible with your localization of pulpal pain is difficult. Localization of periradicular pain is comparatively easy and becomes more difficult as the pain intensifies. Irreversible pulpitis pain is the pain which is highly one of the most painful experience of a human disease. Okay, it's a toothache which is signaled by irreversible pulpitis per se. Application of external stimuli such as cold or heat may result in prolonged pain and more to thermal. EPT is electric pulp testing can give a little less response, especially the major response is to cold or heat. Then comes pulp necrosis. This indicates death of the dental pulp, necessitating root canal treatment. Irreversible pulpitis also necessitates root canal treatment, but here it is the category where even the putrefaction has happened. The pulp is non-responsive to pulp testing and is asymptomatic. The nerve fibers are itself dead. Pulp necrosis by itself does not cause apical periodontitis. The death of the pulpal tissue, it doesn't mean it is causing the periapical radiolucency, which we say as apical periodontitis or pain on percussion, unless the canal is infected. So root canal gets infected and then takes the inflammation deeper into the periapical region, and here it is periapical or apical periodontitis it becomes. Some teeth may be non-responsive to pulp testing because of calcification and recent history of trauma, or simply the tooth is just not responding. As stated previously, this is why all testing must be of a comparative nature. Example, patient may not respond to thermal testing on any teeth. So this is you have to test a normal teeth first, then the tooth which is having a cavity. So patient may be not responding to any of the teeth, right? So we have to check with the reference of the healthy clinical teeth. Then we have pulp has rigid walls, hence increased pressure. The venules and lymphatics collapse, leading to necrosis after irreversible pulpitis. If exudate drains through caries, necrosis is delayed, but if sealing of closed or closure of the pulp occurs, necrosis is fast. So there are two ways the mechanism continues. One is that slowly the decay is progressing, the dentine is being evacuated from the top. So here necrosis is a bit delayed. But if the top is healthy, or there is just one point of entry, say mesio-occlusal caries, and from there it is reaching whole of the pulp, and above is a top closed container. Okay, inside becomes like a pressure cooker, because inflammatory mediators are creating more of the cytokines, more of the whatever inflammatory mediators chemistry you can recall the names. And these are building up the pressure inside a vesseled tooth until and unless the patient gets the immediate access opening comes to a dentist and get the immediate access opening done. It is like a increased pressure and unbearable pain. So that's why in most of the clinics in India, it is advertised, get pain relief in single sitting, pay, Indian currency, some 1,000 and 1,500 rupees and get your pain relief done. All they are referring to is get the access opening done, because that is the one which gives instant pain relief. No matter patient keeps on eating ibugesic, or patient keeps on eating Voveron, which is diclofenac, it doesn't relieve the pain, because it is, or relieve the pain for a minimal amount, 1 or 2 hours, and again the patient is having severe shrieking pain. So this is because of buildup of the pressure, buildup of the volume inside these pulp tissue. Then discomfort on pressure to periradicular tissues. It goes deeper and creates a periapical abscess per se. Cold, heat, or electric stimuli applied to teeth with necrotic pulps usually produce no response. If it is necrosis, the A, delta, and C fibers are dead, then it produces no response. So that is one of the determinant of pulp vitality test when we say that the tooth is dead. It needs to go for RCT. Then this is one of the pulp condition. Again, irreversible in nature, but here pulp producing cells, fibroblasts get active, create on producing pulp tissue, which we say as pulp polyp, hyperplastic growth, a cauliflower-like growth emerging from the tissue, tooth tissue. And imagine the hard tissue of the tooth is decayed, gone down by the bacteria. Inside, the pulp is still expanding at the cost of, because inflammation is stronger. And the bacteria were able to demineralize the hardest tissue of the human body, which is enamel and dentine. That was eroded, but inside, the inflammation has much more power to take the battle to an extent that now it is the pulp is growing through and through. And this growing also is leading to a hollowing out of the tooth from within. So it is, which is called as pulp polyp or hyperplastic pulp. It is low-grade chronic irritation of the pulp. Whenever something is building up, it is always low-grade, be it internal resorption, be it external resorption, be it replacement resorption. One type of cells is cell type is going haywire. It has determination to proceed on growing. So that will take some while. It will not happen overnight. So that is why it is a chronic condition. A type of, and also it won't be painful initially. Otherwise, the patient can see this kind of a thing in their mouth, but they would not visit the dentist, because even if it is a chronic condition, because it is less painful. The innervation is already dead, much of it. What it is, it's lot of vascular tissue. Blood is here. Also, sometimes it may become painful later on. Then the patient would come like, because again, now it is exposed to open foods and drinks and putrefaction of whenever the patient eats, then it starts troubling them. But for a while, till they visit a dentist, it is not much troubling. It is also a type of irreversible pulpitis and young pulp due to generous vascular supply. It usually happens in the young permanent teeth. Also happens in the primary teeth. Okay. Then we have pulp calcifications. Here, odontoblasts became active, or they started producing inside, it was to have a sound root, patent root canal, but here we cannot see a patent root canal. So it has filled the tooth with calcific matter. That is what is pulp calcifications. It usually occurs in response to trauma, caries, periodontal disease, or other irritants. Thrombine, blood vessels, and collagen sheets around vessel walls are possible sources for these calcifications. Another type of calcification is the extensive formation of hard tissue on dentine walls, which is seen here, often in response to irritation or death and replacement of odontoblasts. The process is called calcific metamorphosis. Here, yellowish discoloration of the crown can be seen. Pain threshold increases because the soft tissue is being replaced by the harder tissue. Calcium takes over, and teeth are unresponsive to tests. Gradual narrowing of the root canal occurs. Right.